Hi, everyone. I'm John Kenlon, Senior Vice President at Ensemble IQ and publisher of Drugstore News. Welcome to today's webinar, Using Social Determinants of Health Data to Supercharge Outreach and Engagement. Today, LexisNexis Director of Solutions Executives, Wendy Yuan, and Andrea Green, Manager Healthcare Strategy at LexisNexis, will demonstrate how to take a data-based and a real-world-based approach to improving patient outcomes. For our audience, we will take questions at the end of the broadcast. Please use the Q&A function that's at the lower left-hand corner of your screen, just underneath the presenter headshots. We'll get to as many of the questions as we can. If we don't, Wendy and Andrea will come back to you. There will be a recorded version of this broadcast available a couple of hours after the presentation today. We'll also do coverage in the Drugstore News daily e-newsletter with a link to the presentation so you can share it with your associates. So Andrea, are you ready to get started?
Yeah, I sure am. Thank you so much. Thanks so much for having us here today. So here's the agenda for today's presentation. We're going to go over some market trends and then an overview of our LexisNexis SDoH product and a little bit of background on how it was built. And then we'll dive into how you can really operationalize that data and use it to start improving your patient health outcomes. So let's get started. So here are just a few statistics as to why SDoH is so important. And I'm sure many of you have already heard a lot of these. We've known for a long time that social isolation, education level, neighborhood safety, individual poverty, and income inequity are all social determinants of health that we really need to start paying more attention to. We know that 1 in 3 deaths in the US are caused by social factors like low education and inadequate social support. And the CDC has told us that heart disease, stroke, cancer are all some of the leading causes of death. And the pathophysiology of those diseases are things like high blood pressure, high cholesterol, and high stress. The sources of those factors are often due to lifestyle behaviors like smoking or unhealthy food choices and lack of physical activity or even alcohol use. So looking at those social factors and premature deaths is not just about, tobacco use or alcohol per se, but, what's really causing people to use tobaccos or have these types of lifestyles? Is it lack of education or increased stress level? Why are those people inactive? Do they live in a neighborhood where maybe they don't feel safe walking around outside? Or, do they have a way to pick up their prescriptions or get to their routine vaccination appointments? Knowing the true stories and the true sources and reasoning behind these behaviors is really what will help drive your next steps to achieve those positive patient outcomes. So why do we need SDoH? Looking at all those social and economic factors affecting health, we can see how it impacts our healthcare system overall. As a nurse, this statistic really stands out to me that at least 25 cents of every healthcare dollar is spent treating conditions that result from potentially changeable behavior. So this goes back to things like high blood pressure, high cholesterol, chronic respiratory conditions, all of which tie back to social factors like education level, neighborhoods, social connectedness, financial stability, and even stress. And every large reputable health agency acknowledges the impact and the importance of addressing SDoH. So some of the market and regulatory drivers behind all of this show us, 50% of patients don't take their medications as prescribed. Why is that? Do they not understand dosing instructions? Or maybe do they not have a ride to the pharmacy to get their refill? Or are they working in a job where their schedule doesn't match up with the operating hours of their nearest pharmacy or their medical provider? Maybe they can't afford their refill, so instead of taking 2 tabs as prescribed, they're only taking 1, and they're trying to stretch that prescription out, right? So we know that patients managing chronic conditions like COPD or CHF can really be one takeout meal even from, or a potato chip away from an inpatient hospital stay. You know, their health is just that fragile, which makes it even more important for them to participate in effective medication therapy management programs. We're finding more and more studies come out that talk about how SDoH has impacted COVID-19 outcomes. For centuries, you know, we've known that pandemics have disproportionately affected the poor and the disadvantaged, not only affecting people of color, but also examining the ability to properly social distance or quarantine in households that are multifamily or multi-generational due to financial constraints or maybe even cultural preferences. And in regards to vaccines, you know, there was a research letter that was published in JAMA Oncology last month, and it talked about how a healthcare organization targeted marginalized populations for COVID-19 vaccine outreach, because patient portals or electronic web-based solutions are often required for most healthcare systems just to be able to set up an appointment for a vaccine. And we found a lot of the elderly population who didn't have email addresses or access to computers or smart devices or even internet for that matter were being kind of left in the dust when it came to scheduling vaccine appointments. And for the most part, these are the populations that really needed those vaccines the most. And then also, you know, mass unemployment. That's led to a multitude of new needs and SDoH concerns, right? Patients are now struggling not only to pay for their medications, but also things like groceries and rent. So along with unemployment, social isolation is also having huge lasting effects on mental health and even motivation to manage one's own medical care and overall well-being. So the need for SDoH data really boils down to the fact that self-reported information from patients is not always reliable. You can ask your patient screening questions, but the accuracy and reliability of these answers are often dictated by time, right? How much time you have with the patient, the trust level that you might have, or the relationship that you might have with them also, right? So sometimes patients are reluctant to disclose information on housing insecurity or food access because maybe they're embarrassed, or maybe they don't want to be judged or generalized. Maybe they haven't established a trusting relationship yet with the person that's collecting that information, and they're worried about being questioned on the ability to care for their children or even their spouse. So patient surveys should really be kind of just a part or a portion of a multi-pronged, comprehensive approach to identifying relative states of health inequity or disparities. So SDoH data can provide those insights that may not be really apparent or forward-facing to help identify who is at that end of that inequity spectrum, right? Who's the most at risk. So you can't do anything if you can't find or identify who they are. And with those insights, organizations can really hone in on the need that exists or the problem that needs addressing and plan for that targeted programming or that resource allocation and patient management and engagement. So a little bit about LexisNexis Risk Solutions. You may have heard of LexisNexis and our legal solutions. We're an industry leader in over 40 years of experience in identifying, calculating, and mitigating financial risk, and also in the auto industry sector, the auto insurance industry. We're a growing company. We have customers in more than 100 countries. All top 10 pharmacy retailers are some of our customers. 8 of the top 10 life science companies and 90% of US commercial payers are some of our customers too. And, you know, because we kind of have that really good understanding of identifying and consumer data is really what we do, it's led us down into that healthcare risk. So this slide is kind of a lot. It's really about the depth and the breadth of our data. So we have over 13,000 unique data sources. Not only do we have public data from things like bankruptcy records, property taxes, professional licenses, court records are on there, but we also have proprietary and other alternative data like accident reports and business records. We have motor vehicle data, utilities, education, phone records, death records, and many, many, many more. We have over 6 petabytes of data. So just to give you some perspective of what that means, 6 petabytes is a high definition video that plays continuously for 79 and a half years. So that's how big 6 petabytes of data is. That's how much data we have. Not only do we have a lot of data, but our data has been curated and validated against clinical outcomes. So we're able to create valuable insights to help you better and more quickly identify the good from the bad. And they can help for predictive modeling, risk stratification, and care management insights to improve health outcomes and increase health equity. So with all that, giant pool web of data that we have, we aggregate all this information into about 280 million living unique LexisNexis identities. So LexisNexis is able to create what we call a Lex ID for each individual adult that we have data on. So let's take Laura, for example. The Lex ID creates like this envelope for information on Laura, and new pieces of information might come in daily, weekly, or monthly, and they might all relate to Laura. And this can include lots of things like old roommate information, driver's license updates, utility bills. And the Lex ID drops those little pieces of information into Laura's Lex ID envelope. So we're unique because not only are we able to look at Laura's financial history, but we can look at her more holistically. So let's say she's what we call underbanked, where she doesn't have a lot of financial records or loan history. We have enough data from other sources that we can determine who's in her household, who she might be married, or maybe she's living with somebody, a roommate. And just because she doesn't have a lot of financial history, maybe she's living with somebody who does. And LexisNexis is unique because we have a better fill rate. So what that means is we can find more people. This allows us to account for social factors like who lives in the household and what's their income. If Laura doesn't have a car, maybe they have a car. So getting to a grocery store 4 miles away or making it to her follow-up appointment isn't that hard for her to do, but also looking at those social connections, we're able to determine social isolation, which is really big in SDoH, especially recently in the pandemic, and other things like, how close do they live from their nearest relative? So one of our key differentiators is the fact that we have a unique library of attributes. So our SDoH attributes have been statistically validated by data science experts to have predictive power in improving accuracy of models that predict health risk. So we only include the attributes that have been proven to be correlated to health risk. So we've got this giant pool of data, and what we've done is we've kind of parsed it out so we know which attributes are the most predictive when it comes to health risk. And it was built with healthcare specific targets and outcomes in mind. For the sole purpose of research, we started with this giant database, right, filled with medical claims with health outcomes of over 50 million identities. And then we took our database of over 4,000 data elements and used targets of things like total cost, hospitalizations, ER frequency, prescription drug costs, and health engagement, and identified our 442 SDoH specific attributes that are indicative of these the 4 out of the box scores that we do provide. So, the left side of the screen talks a little bit more about these 442 attributes that can be combined with your own data elements in order to create your own predictive models or to help augment the predictive models that you have or improve the accuracy of the predictive models that you have. Or we have our 4 pre-built scores that address certain socioeconomic categories. So our total cost risk score is going to predict the level of cost a patient may incur in a 12-month period. This is not necessarily indicative of the patient's ability to pay. Rather, it's how much their healthcare might cost over the course of 12 months. Our readmission risk score helps predict the likelihood that a person will be readmitted to the hospital within 30 days. Our medication adherence score helps predict how likely a patient is to take their medications as prescribed. So, like I said, especially during the pandemic, it isn't unusual to see patients hoard their meds or ration their prescriptions instead of taking them as directed. So this medication adherence score can really help direct you toward those who might be statistically more likely to kind of veer off of that prescribed path. This can be really impactful information to have, especially when you're managing the care of really sick or fragile patients that might have those chronic conditions. Our health engagement score also allows you to understand which members are likely better to kind of self-manage their own health or actively participate in their care management plan as directed by their care provider. So, and lastly, we offer our care drivers that we return for each individual. So this is really important if you need to better understand the why behind the scores, right? So what are the attributes that drive that score to be what it is? These are care drivers. These care drivers can really be instrumental in discovering not only the why, but the what we can do to help ease some of those burdens or remove some of those socioeconomic barriers. And Wendy is going to talk a little bit more about that later. Next slide, please.
It should be on the advisory services, is it not?
I don't see it. There we go. Thank you. So LexisNexis also has advisory services offerings aside from just the data that we provide, which makes us really unique in the SDoH world, the data world. Because not only do we have the data, but we have the knowledge and the expertise to assist organizations in kind of combing through that massive amount of data that we provide and really forming those actionable next steps. So our advisory services partners, they partner with our clients to provide expert consultation and using LN data to kind of be proactive to the needs of the individuals or the communities. So we can help healthcare organizations form a comprehensive, multi-pronged approach to addressing SDoH barriers to meet the social services need that can impact the health behavior and then ultimately improve the health outcome of the patients. So now I'm going to hand it over to Wendy, and she's going to talk a little bit more about how you can use SDoH for patient outreach and engagement.
Thank you, Andrea. So now that Andrea has gone through how our products were designed and built at a high level, I want to go into a little more detail. So here we have, where Andrea touched on earlier, we have 442 attributes, and they're all correlated directly to health outcomes. And what we've done here is categorize them in the 5 main socioeconomic categories you typically see. So you can see we cover economic stability, education, neighborhood and built environment, social and community contacts, and transportation. Here are just some of the types of attributes that fall under each of these categories. And those types of attributes that we handle or cover are things like address mobility, estimated income, financial health, education level, neighborhood financial value, community engagement, household information, and transportation access of the patient and their relatives. All of which is very important in understanding and having a bigger picture of a patient's life. For example, if you were to take a look at Andrea and I, 2 women in the same age group, relatively healthy, and say we lived in the same neighborhood, many would assume that if you knew something about Andrea, you could also assume the same stuff about me. Well, what if I have children under 18 and elderly living in my household, and I only have a high school degree and my total household income was vastly lower than Andrea's? And then let's say Andrea is a registered nurse, has a master's degree, doesn't have any children or elderly to take care of, and her husband makes 6 figures. You might start to see some key differences in how you might think about working with each one of us differently due to our socioeconomic needs. What I want to do is emphasize how LexisNexis has the ability to pull this level of data for each individual in your patient population. This is helpful at the individual level by understanding the reasoning behind why each patient may behave or not behave in a certain manner. It is key in helping them overcome any socioeconomic barriers they may have and lead to improving their overall health as you can start to see when I was painting the picture of the differences between Andrea and I. We can also assess your entire patient population by aggregating the data up to help assess socioeconomic barriers to health for specified populations, and then help with decisions on where to build programs and where to leverage existing programs. I'll take you through some detailed examples very soon. In addition to our attributes and scores, Andrea also mentioned we have socioeconomic or SDoH care drivers. I want to go into a little more detail about this because I think this is very important for your pharmacists when they're handling care. These care drivers provide insights into why a patient received their specific socioeconomic score and can be leveraged by those managing your patient populations and interacting their care directly. In your case, pharmacists can use these care drivers to determine how to interact with their patients directly, especially since we know that a pharmacist's involvement in clinical preventive services, chronic disease state management, and transitions of care are all vital to the elimination of health disparities. What specific questions can the pharmacist be asking when they do see the patient? How can they make their patients' lives easier by removing any medication adherence barriers? So I want to explain what a care driver is. A socioeconomic care driver is a combination of our health attributes that indicates a potential socioeconomic health barrier for a patient. These care drivers are created to help you address socio-determinants of health barriers to improve health outcomes for your patient population. The care drivers answer why the individual is at a certain risk level so that the socio-determinants of health barriers can be proactively addressed before health conditions develops or worsens. This is the information that can directly impact your patient interactions and put your organization's initiatives into action. For each individual and each score, we will return the 3 highest care drivers that impacted the risk of the score, and the 3 lowest ranked SDoH care drivers are those that did not impact the risk of the score. These are things such as address mobility, financial health, social support, and transportation access. This provides more insights into which socio-determinants of health barriers have the most and least influence on the patient's health engagement or medication adherence rate. They were designed to be easily ingested and viewed and interpreted by your pharmacists as needed, mostly when they're interacting with their patients directly. So how do we bring all these parts of the solution together? Here are a few high-level examples on how you can integrate SDoH data both globally throughout the community and locally within your own organization. Pharmacists are often considered the most accessible health professional in the community. The frequency in which a patient enters a pharmacy surpasses the frequency in which a patient enters a provider's office or a hospital setting. SDoH can be integrated into pharmacies by using insights about individual patients that you serve to find a solution or intervention that can help them in overcoming potential barriers to care. Some pharmacies have started utilizing SDoH specialists to help connect their patients with community resources like fresh food deliveries, mobile farmers markets, or even companionship programs. You can use SDoH data strategically by using it for funding requests to gain government or commercial payer contracts, as well as looking at resource allocation or other potential program implementations to help improve the overall health of the community or population in which you serve. SDoH insights can also be used to help improve communication and effectiveness of medication therapy management programs and services. So really tailoring the conversations that you're having with the patients. So I want to give you a couple more examples in the next couple of slides. And so what I'm going to do first is we want to talk about identifying the patient population you'd like to pull the SDoH data on. And then secondly, I want to show you what kind of details of information you're going to get for each patient when you pull scores and attributes. And then thirdly, I want to talk about interpreting the data that you get, translating it into how you might interact with that specific patient so you can target your interventions and outreach, and also help determine which programs to build out or leverage. Now that I've set up all those details, let's walk through a few scenarios together to better understand how we can help provide SDoH insights at the individual level first. So as we alluded to earlier on how pharmacists are on the front lines with helping patients manage their medications and chronic conditions, we know approximately 20 to 30% of prescriptions are never filled, and 50% of medications for chronic diseases are not taken as prescribed, just like what Andrea mentioned earlier. We can help in terms of managing those patients' diseases and ultimately managing their health effectively, efficiently, and at a personalized level. We can help answer who is likely to be non-adherent, we can help answer, how can it be prevented? We can ultimately help improve medication adherence and patient health outcomes, and therefore impact your medication therapy problem resolution monitoring measures and your completion rate for comprehensive medication review numbers. So say you're behind the counter as a pharmacist, and you're seeing these 4 men come to your counter to fill prescriptions at your pharmacy. Each of these men are 55-year-old. They have diabetes and COPD. They look very similarly on the clinical side of things. But let's take a deeper look at the pairs up closer. We can see here that upon pulling their individual socioeconomic data, they're starting to look very different. So let's say that Jack and David are already customers at your pharmacy. They might look the same clinically based on gender, age, and diseases. You also have their medication histories and past behaviors. However, when we pull the LexisNexis SDoH data, we can see that Jack has bankruptcies, no education, lives in a high crime area, and lives very far away from his relatives. If you wanted him to manage his diabetes and COPD, you might have to put in more effort to help him remove some of his socioeconomic barriers, such as provide him more one-on-one education, or help him enroll in a mail-order pharmacy program if he cannot come to the pharmacy regularly to pick up his medications, or if he can't come easily. On the other hand, we can see that David does not have any bankruptcies, has a master's degree, lives in a safe neighborhood, and his nearest relatives live pretty close to him. He may not need too much intervention when it comes to managing his diseases and engaging in his own health. David might just need to be asked if he got his flu shot this flu season, or if he needs another routine screening or other vaccinations like his pneumonia vaccination while he's at your pharmacy. You can see here, managing each patient based on their individual socioeconomic needs could impact your quality measures, such as your MTPR monitoring measures or your CMR stats, like I mentioned earlier. We can provide this level of data for each patient and reduce the amount of time necessary for consultations. So basically, consultations can now be more targeted and efficient, since we all know your pharmacists all have so much to do day to day, filling prescriptions and talking to patients individually. Here, we have 2 new patients that just walked into your pharmacy, and then you're going to be working on getting their prescriptions filled while they're waiting. They look very similar in the fact that they're both 55-year-old men and have diabetes and COPD as well. However, if we took it to the next step, we see if we pull their socioeconomic health score, they look very different. I didn't go over this one earlier. In the case of this socioeconomic score, the higher the score, the lower one's health engagement. So that means Will's score shows he is less engaged in taking care of his health, and therefore might need more intervention. You might ask him more questions and guide him on whether or not he may benefit from a community support group. Or would he like to enroll in a mail order delivery program right now as he's picking up this new prescription? Or does he need any discount drug services? Whereas Peter's socioeconomic score shows he's highly engaged in his own health outcome. Therefore, Peter may need some help, such as gentle reminders for prescription refills. So you might ask if he'd like to enroll in an automatic refill for this particular prescription. Or you might ask if he needs routine screenings or other vaccinations while he's waiting at your pharmacy. Layering on that individual level score shows a completely different story on how you might approach each patient differently to keep them engaged in managing their chronic conditions. Now, I want to pivot and talk about how can you look at your patient population as a whole. I mentioned this ability in an earlier slide, and see if there are areas where you can make business decisions using this data. We've helped other clients gain insights into their patient populations using our SDoH data in this manner. In this example, we have transportation challenges. Science, we basically started by looking at those patients that do not own a vehicle in our records. Then out of that population, which patients do not have any vehicle registrations within their households. Then out of that population, their relatives and associates don't have any vehicle registrations. And then finally, looking at that subpopulation to see if there are individuals that live in an unsafe neighborhood. They were able to use this information when building out a business plan to partner with a rideshare company. They were able to target these patients' socioeconomic barriers and address their needs directly. Perhaps a need to target your customers or patients in an unsafe neighborhood and establish or provide free mail delivery of prescription medications. Perhaps you see the need in investing a pharmacy location at a specific region in your community where you see patients could benefit from having a pharmacy location closer to them. Ultimately, we can slice and dice the data how you see fit to achieve your organizational goals, and many examples of how you can use our SDoH data. I just went through how we can take an existing patient population and apply our SDoH solution to fit your organization's goals and initiatives. Patient population list. We also have the ability to pull population level SDoH data. This is different, as these are not your current patients. Tell us what geographic region you want us to pull. We will pull the SDoH scores and attributes for all the individuals living in that location, aggregate the data to determine if there's a socioeconomic need in a specific geographic region based on the attributes connected with those individuals. So therefore, our census tract data will look different than those just extrapolated off of the census tract instead of gathering the individual data level data first and then aggregating it up. Or invest in new initiatives to reduce socioeconomic barriers and improve health equity. Graphic stats reports as a part of the service. And then I must mention that any census tract level data with less than 50 people will be aggregated up in order to maintain anonymity. Because now I want to pick an example population to talk through how to use the population level SDoH data on conditions just like diabetes. In the Journal of Ethics, they discussed how physicians and pharmacists collaborate to motivate health equity in underserved communities of African Americans who receive medication therapy management services from a pharmacist significantly improved their diabetes compared to 23% in the control group. Additional public data research on diabetes, things such as expenditures for diabetic patients are 2.3 times higher than patients without diabetes. Lower socioeconomic status were more likely to have higher HbA1c values, financial distress, those that live in disadvantaged communities, and have lower educational attainment showed a significant indirect impact on their HbA1c through depressive symptoms, health literacy, and social isolation. And food insecurities are more likely to have poor glycemic control. These are all indicators or clues in someone's socioeconomic data that might indicate an individual may be struggling with type 2 diabetes or at risk for being at LexisNexis have this exact level of data on individuals, and we can use this information to determine the overall health of a population of your choosing to help your pharmacists make an impact on your community. All of those socioeconomic needs I mentioned in my previous slide translates directly to the attributes and care drivers we have in our solution, and I've listed a few in this slide. Things like education history, neighborhood financial value, financial health, and social support are just a few to call out. We can provide all of that information at the individual level and then aggregate it up. Maybe you will see that the population you wanted to understand shows low educational attainment or low health literacy, and poor neighborhood financial value, and social isolation. This might help you determine if you want to start a diabetic education initiative in a particular geographic region, offer if they have fresh groceries along with the delivery of their medications for those with groceries available. Or take it further than just diabetes. Make an investment in mobile clinics in a specific community area for seasonal flu or pneumonia vaccine campaigns, or routine screenings, or basically any other goals your organization may have to help foster community engagement and reduce health disparities. You can look as high a level or as granular level as you want to get insights on a particular population. Earlier, I listed out some specific attributes you might be interested in if you were to target a diabetic or pre-diabetic population, and then use that information to determine where you might want to invest or set up programs. Here, I have a distribution graph showing a Northeast metro city's health engagement scores in comparison to a normal population. The higher the risk, the lower the patient's engagement again. So it's not a surprise that we see the disadvantaged socioeconomic neighborhood represented in red here shows less health engagement than a standard population. It's not a surprise because we know that they're constantly worried about food security or where their next paycheck is coming from. It just means they have less urgency to prioritize their health since they're worried about their means of living. I just think that this is very interesting because when we look at population level SDoH data, we've not ever found any two urban metro cities that look the same in the data studies we've done, even though you would hypothesize most urban cities will look the same. But because we're able to show you and get to the level of information, we can show you how you might treat or strategically approach each city differently as well because of the data we do have. There's just so much data out there, and what we've done is basically inundated you with so much more data during this presentation. What we've done here at LexisNexis is simplify this information to make it more actionable. We provide these industry best practice tiers based on our scores in order to help you ingest the data more easily. Knowing where your population lies, for example, and how engaged they are on a scale can help you map out an action plan effectively, such as knowing that you might need to send postcard reminders or texts to those patients like David or Peter, those example patients that we were seeing in our pharmacy. Or maybe you can arrange for free mail delivery of maintenance drugs for those that have transportation issues. Again, thinking of this from the population level in a specific area, you might see the need to have more mobile clinics or a need for targeted education campaigns, so you might make smarter investments in certain areas of your coverage. Once we provided the data, created it, and sliced it into what else can you do with this population level SDoH data? I've already mentioned a few in my slides earlier, but you can identify neighborhoods with socioeconomic needs and then focus your attention and initiatives where the need is the greatest. You can partner with community service organizations to address identified barriers to care, such as provide mail ordering prescription options to those that might need the service. Or, for example, some pharmacies are partnering with local farmers markets to provide fresh produce to patients coming into the pharmacy to give them better access to fresh foods. Others might partner with a rideshare organization to remove any transportation challenges if they need to be physically seen by a pharmacist or pick up their prescriptions if mail delivery is not an option. Or partner with local social support services to address those living in social isolation. And then Andrea kind of mentioned this earlier, but some organizations are using analytics and electronic health records to conduct targeted COVID-19 vaccine outreaches for those populations that may be left out due to the lack of digital communication channels. Basically, this entails finding patients who may have fallen through the cracks, such as those that are elderly or those that may be disadvantaged. These are the people who are known to be less inclined to know how to use technology, or perhaps they don't own a phone or have an email account or have access to internet. And these are some of the groups that might need the vaccine the most. There's just so much potential with this level of data. I hope that I've given you a lot of ideas to start turning those wheels. Let's start by discussing our organization goals and initiatives and see where we would recommend you start. And lastly, I just wanted to summarize everything Andrea and I just talked through today with you one more time. We just explained how socio-determinants of health are a known hot commodity in the healthcare industry right now, and LexisNexis is well positioned to provide individual level socioeconomic data. We can globally look at current patient populations or populations of your choosing to identify those at risk and help you make long-term investment decisions. Then we can look at this data locally by identifying at-risk patients to target with programs to improve their health outcomes, health engagement, and medication adherence. Lastly, we want to help start by giving you the data to operationalize the data and putting it into the right hands within your organization to start making an impact towards health equity. And now I want to hand it back to John to facilitate our Q&A session.
All right, thank you very much, Wendy. I took a lot of notes. That was comprehensive. Thank you so much. You know, I was thinking while you were both speaking that Drugstore News reports almost every day on personalized care, and I thought how interesting that you guys are basically building customer profiles that accurately predict how patients are going to behave, and it identifies the barriers, anticipates them, and then provides solutions so you get better compliance and better health outcomes. So that's really fascinating. And I was also fascinated by the number. I think you said in the beginning, I think it was Andrea said 25 cents of every healthcare dollar is spent on some preventable or changeable rather behavior. And I didn't realize that. I'm sure most people in our audience didn't realize that. So there's a lot of room to improve. I have a question. You mentioned that I know the company works with all of the big players. What if you're a regional chain? Is there room to do business with LexisNexis?
Oh yeah, absolutely. I mean, we have customers that are big and small. So just depending on, how big your patient population is and how much, you're really looking to change, what your goals are, we absolutely work with smaller regional chains.
Wow, that's good to hear. I'm glad. All right. So let's move on to a couple of questions here. Let's see, hang on one moment. All right. Where do you get all of this information about people, and how do you ensure that the data is used ethically?
Yeah, so that's a really good question. There's a little bit of this like spookiness factor because we do have a lot of data on individuals, but really a lot of our data sources are public sources, and then also we do have proprietary sources. So we constantly aggregate data from public sources and our proprietary data sources on individuals to keep making sure that that data on that human life or that Lex ID is up to date and current. Our data is GLBA regulated, so credentialing is required. Customers really have to attest to having permissible use.
Okay. All right. So who wants to take this one? Couldn't this data be used for other purposes like marketing or setting insurance prices higher for high-risk patients?
Yeah, I'll take that one again. So because our SDoH is GLBA regulated, it can never be used for marketing purposes or price setting. So we really make sure that we have these conversations with our customers and they understand that what permissible use is. And we include language in our legal agreements and make sure our customers are really using what we call data for good.
Excellent. Hold on a second here. Got another question. We got a couple of questions coming in. There's a question from a retailer asking, do other organizations sell their information to you?
So that's, I'm not necessarily sure I understand the question. We do purchase data from private organizations, but not healthcare organizations. So right. We don't buy data from healthcare organizations on their patients because of HIPAA laws and things like that. So healthcare organizations do not sell us their data.
Okay. And what information do we need to send to LexisNexis in order to get the patient level SDoH data?
That's a Wendy question.
Oh, Wendy, can you take that one?
Yeah.
Yeah, of course. Hopefully you guys can hear me okay. But in order to get to the patient level SDoH data, what we would need is basic patient demographic information, things like a full name and a full address. We can also take in social, but it's not required. Phone numbers, emails, date of birth. Date of birth is actually pretty helpful as well to help in those situations where there's juniors and seniors.
Okay. So here's another question. I'm not sure who should take it. Many pharmacy organizations focus on certain populations by disease state that they gather from their dispensing business. Can a pharmacy initiate SDoH modeling within only one category, like diabetes, for instance, or could the focus be gathered for those patients 65 and over, for instance?
I can take that question, I think. So that's a really good, there's a couple of different ways that you can look at look at the data and look at kind of what your next steps are going to be for your business. It really depends on what your organization's initiatives are. And, I think that you have to kind of allow for the data to speak to you as well. So diving into something and really being very specific on one disease state can be effective if you know that your patient population is heavily affected by that disease state. So we can absolutely kind of hone in on that and focus on that. But also we want to make sure that we don't forget to look at the data holistically. And that's another place where our advisory services and our data science team can kind of assist with that, because you really want to be able to evaluate the data that you have and then look at what your next steps might be. So are you really focusing on that that older population, or just the diabetic population, or maybe where the two overlap?
Okay. Hold on, we've got a whole bunch coming through here. Let me just get, all right. Can you talk more about how, was the medication adherence model built, or what it's based on?
When did
should
you
should I do that one? Should I read that one again?
Yeah, could you?
Yeah. So can you talk more about how the medication adherence model was built, or what it's based on?
Gotcha. So yeah, our medication adherence model, what we did was there's a lot of kind of technical aspects of it, but we looked at medical claims data and clinical data, and our statistical analysts and our data science team looked at correlation analysis and different types of statistical modeling. I'm not super familiar with how they do all of that, but they were able to kind of overlap the two and see where which attributes were the most predictive, and then looking at the medical outcomes from the claims data that we did have.
Right. Let me see. I think. Yep. All right. Do you think, now we spoke earlier and we said the presentation would be available for download at the end of the broadcast. So everybody, if you want to see this or review it, you will be able to download it just after this broadcast. Wendy, Andrea, are we leaving anything out here? Do you think there's anything else that we need to cover? I know it was pretty comprehensive. There's quite a few data points there.
Yeah, you can always contact us directly if you have if anybody has any additional questions. There it is. There's the connect with us slide, and we'd be really happy to reach out to you and see if we can help you with your SDoH data.
You have one last question here that I think we have time for. Says, how do you get your claims data? This is a great solution. Is that something we can talk about?
Yeah, so it really depends on the customer. So usually the claims data that we get and that we use are our customers' claims data. Does that make sense? So we're not purchasing identified claims data from like some giant database where we know, or from like a warehouse or something like that. The claims data that we use with our statistical modeling for our customers are usually our customers' claims data.
Excellent. Got it. Okay, we are running up against a hard stop here. Wendy Yuan and Andrea Green from LexisNexis, thank you for a truly comprehensive presentation. We hear the retailers talking about social determinants of health constantly, and it's not going away. It's something that all of them want to resolve, especially as they play a larger role in delivering healthcare through the clinics, and whether they're doing testing or whether they're doing vaccinations, it's only going to increase. So thank you so much for your time today. Remember, everyone in the audience, we will have a recorded version that's available in a couple of hours. You will see it in tomorrow's daily newsletter, Drugstore News. And get in touch with the folks at LexisNexis if you want to learn more. Thank you very much.
Thank you.
Have a great day.
You too.